Welcome to this audiobook on tuberculosis. Let's begin by looking at screening for tuberculous infection versus diagnosis of active disease. When screening of asymptomatic patients, we should consider the risk of infection. Do they have a higher than usual risk for infection compared to other people in the US? Such cases include a. Recent exposure to person with active TB. This is important. B. Lab personnel. C. Immigrant from high-burden country. And D. Homeless, incarcerated, institutionalized individuals. Those at risk for disease include a. Children below the age of 5 years. B. HIV-infected, otherwise immunocompromised individuals. C. Patients with abnormal chest radiograph. D. Diabetes, chronic renal failure, intravenous drug use. We will now discuss diagnosis in symptomatic patients. It is done using 1. A chest radiograph. 2. Sputum smear for acid-fast bacilli, AFB. 3. Sputum culture for mycobacteria. 4. Sputum nucleic acid amplification test, NAAT, for Mycobacterium tuberculosis. Evidence of systemic Mycobacterium tuberculosis infection includes 1. Interferon gamma release assay, IGRA, which has 3 components: negative control, positive control, and impact of patient's serum on leukocyte activation. And 2. Tuberculin skin test, TST. Let's now discuss screening for latent Mycobacterium tuberculosis infection. Let's address the question, whom to screen. We should screen the following: 1. Household contact of or recent exposure to an active case ***. 2. Mycobacterial lab personnel ***. 3. Immigrants from high-burden countries ***. And 4. Homeless, incarcerated, institutionalized ***. How about students and healthcare workers? Many schools or healthcare institutions require screenings of students for latent infection, but it may be unnecessary for the test to be done annually in this patient population. *** denotes patient groups at risk for infection due to Mycobacterium tuberculosis. Let's now address the question, which test should be used? We should use 1. IGRA-A. Quantiferin, or T-spot IGRA, which is the preferred method for screening in patients above the age of 5 years. C. There are false positive in low-risk subjects. Therefore, use TST for confirmation. D. It should be preferentially used for high-risk patient groups due to high sensitivity. 2. TST cutoffs. Let's now consider TST cutoffs for patients who are at risk for infection. They include 1. Children less than 5 years with HIV or those who are immunocompromised, those receiving treatment with TNF-blocking agents, those with abnormal chest X-ray, 5 mm in size. 2. Diabetic, renal failure, IVDU 10 mm in size. Individuals with no risk for infection, 15 mm in size, such as a student or healthcare worker. This also applies to those at high risk, diabetic or renal failure, but do not have other risk factors for infection. Let's now consider treating latent tuberculosis. A. The recommended therapy is 1. Rifampicin plus isoniazid once weekly for 3 months. 2. Rifampin once daily for 4 months. 3. Rifampin plus isoniazid once daily for 3 months. Examples of alternate therapy are 1. Isoniazid daily, or twice weekly, for 9 months ***, and 2. Isoniazid once daily, or twice weekly, for 6 months ***. Intermittent regimens must be provided via directly observed therapy. Not recommended for children. Let's now discuss diagnosing active tuberculosis. We can use A. acid-fast bacilli, AFB microscopy on 3 or more specimens. B. Liquid with or without solid cultures of each specimen. CNAAT on initial specimen. D. Sputum collection. This is done through 1. Expectorated sputum, 2. Induced sputum, and 3. Flexible bronchoscopy. Let's now look at objectives of therapy. They include, to A. rapidly decrease the number of actively growing bacilli in the patient, B. eradicate populations of persisting bacilli to achieve durable cure, C. prevent acquisition of drug resistance during therapy, D. Mycobacterium tuberculosis exists in 3 different sites, namely extracellular area, granulomas within lung, and alveolar macrophages. Different drugs are better at clearing the pathogen out of different areas of infection, which is why multi-drug therapy is utilized. Let's look at considerations for initial therapy. The ideal antitubercular therapy would be 1. Multi-drug intensive phase therapy with a minimum number of drugs, ideally 3, for a minimally effective duration equals 2 months, followed by 2. Maintenance drug therapy with a minimum number of drugs, ideally 2, for a minimum treatment duration equals 4 months. Unfortunately, risk factors for drug resistance and/or treatment failure may not allow the use of an ideal regimen. Let's now look at considerations for initial therapy. Directly observed therapy, DOT, is the standard of practice. 1. Noncompliance is the most common factor in the United States leading to drug resistance and/or treatment failure. 2. There is need to observe the patient directly in order to ensure that patient is compliant. 4. Drug-intensive phase therapy is used when 1. Susceptibilities are unknown, are patient, or 2. Drug resistance is documented, or 3. Cavitary disease is present, or 4. HIV infection is present. When should we use daily versus less frequent intensive phase therapy? 1. Daily administration is strongly recommended. Outcomes and success rates are higher for daily administration. 2. Daily therapy Monday to Friday is considered an acceptable option. 3. Thrice weekly administration after 2 weeks of daily administration may be considered if none of the risk factors for resistance and/or treatment failure listed in 3b exist. Pause the video and scrutinize the table summarizing oral drug therapy options for pulmonary tuberculosis found to be pan-susceptible. Let's now look at pharmacokinetics of commonly used antitubercular drugs. We will begin with important pharmacokinetic features. They include 1. Penetration to pulmonary and extrapulmonary sites. 2. Penetration and activity into granulomas and pulmonary macrophages. 3. Oral bioavailability, and 4. Routes of elimination, hepatic or renal. The ability to extend dosing interval is more due to slow growth rate of Mycobacterium tuberculosis than long half-lives of drugs. Isoniazid, INH1. Its penetration into extrapulmonary sites is excellent, it is a good early sterilizer. 2. Its penetration and activity into macrophages and granulomas is limited. 3. Its oral bioavailability is very good, though available in intravenous form. 4. Its route of elimination is hepatic. Rifampin RIF. It is the mainstay for many types of mycobacteria. 1. Its penetration into extrapulmonary sites is good. 2. Its penetration and activity into macrophages and granulomas is excellent. 3. Its oral bioavailability is excellent, though available in intravenous form. 4. Its route of elimination is hepatic. Let's now look at pyrazinamide, PZA1. Its penetration into extrapulmonary sites is excellent. 2. Its penetration and activity into macrophages and granulomas is excellent, its best activity is at lower pH. 3. It is an important component in early sterilization in order to reduce number of organisms, and then in maintenance, hopefully you have knocked down the amount of organisms a substantial amount and do not need this anymore. 4. Its oral bioavailability is very good. 5. Its route of elimination is hepatic, but its active metabolite is excreted renally. Ethambutol, EMB1. Its penetration into extrapulmonary sites is limited. 2. Its penetration and activity into macrophages and granulomas is limited. 3. Its oral bioavailability is very good. 4. Its route of elimination is renal. There is need for renal dose adjustment in renal impairment. 5. It is used in early stages because of initial high inoculum of organisms versus having penetration at a certain area. It is also good if there is concern for resistance. Pause the video and scrutinize the table summarizing antimycobacterial drug dosing. Rifabutin can be used instead of rifampin, especially if drug interactions are of concern. Rifampicin has a long half-life and is only recommended for weekly dosing. With normal renal function, dose of streptomycin is about 25 mg per kilogram thrice weekly. Pause the video and scrutinize the table summarizing pyrazinamide oral dosing in normal renal function. In patients with CRCl 30 to 50 ml per minute, normal doses may be used, but serum concentration monitoring should be performed when possible. It is dosed somewhat based on weight due to adverse events and hepatotoxicity. The dose is 35 to 40 mg per kilogram on average, for thrice weekly, for normal renal function. Pause the video and scrutinize the table summarizing ethambutol oral drug dosing in normal renal function. In patients with CRCl 30 to 50 ml per minute, normal doses may be used, but serum concentration monitoring should be done. This should be performed when possible. It does have dose-related adverse events to be aware of, talked about later. Its dose is 30 mg per kilogram on average, for thrice weekly, for normal renal function. Pause the video and scrutinize the table summarizing antimycobacterial dosing for patients with a CRCl less than 30 ml per minute. In patients with CRCl 30 to 50 ml per minute, normal doses may be used, but with serum concentration monitoring. It should be performed when possible. Let's now look at drug interactions with antimycobacterial drugs. Rifabutin, RFB, is metabolized by CYP3A1. Some CYP3A inhibitors include ritonavir and voriconazole. 2. Examples of CYP3A inducers are efavirenz, an NNRTI, and phenytoin. RFB 450 mg may be considered with potent CYP inducers while RFB 150 mg may be considered with potent CYP inhibitors. INH is a CYP inhibitor, but its effects are often countered by rifampin. It could have an effect on 1. Phenytoin, 2. Benzodiazepines, and 3. Carbamazepine. Let's now look at drug interactions with rifampin. It is a potent CYP inducer. Examples of its interactions include interactions with 1. Protease inhibitors. It is recommended we use RFB instead with PIs. Integrase inhibitors. A. Bictegravir should not be used with RIF or RBN. B. Increase dolutegravir dose to 50 mg twice daily with RIF, NRTIs. Tenofovir disoproxil fumarate, TDF is recommended over tenofovir alafenamide, TAF, at this time. NNRTIs, efavirenz, its empirical dose should be increased. Voriconazole, its empirical dose should be increased. Estrogens, it is recommended we use alternate contraceptive. Methadone, it is recommended the empirical dose be increased. Warfarin, it is recommended we adjust dose based on INR. Phenytoin, valproic acid and carbamazepine. Adjust dose based on drug concentration. Oral hypoglycemics, it is recommended we adjust dose based on fasting glucose or HbA1c. Psychotropics, adjust dose based on drug concentration or effect. pause the video and scrutinize the table summarizing baseline or follow-up testing. A. It is important for testing efficacy and adverse effects that could occur. B. It is the number one measure for success, i.e. the time at which sputum AFB culture becomes negative should be measured monthly, and ideally be negative at 2 months. C. If patient remained culture positive past 3 months, repeat culture should be considered. We will now look at adverse effects from antimycobacterial drugs. A. Neurotoxicity from INH. It can cause peripheral neuropathy and other neurotoxicities. We should administer it with pyridoxine 50 mg orally daily, based on U.S. guidelines. B. GI. It may cause nausea and vomiting. Usually this can be handled by managing symptoms, try dividing daily doses and/or taking with meal. And check LFTs, to rule out hepatotoxicity. C. Rash. 1. If urticaria occurs without mucous membrane involvement, treat with antihistamines. 2. In case of generalized rash or mucous membrane involvement, stop drugs and restart 2 to 3 days after resolution, RIF first, followed by INH, followed by EMB or PZA. Stop last drug restarted if rash recurs. Drug-induced fever. 1. Rule out infection. Fevers from adequately treated TB can last up to 2 months. 2. In HIV-infected patients, consider immune reconstitution inflammatory syndrome if you started ART during course of therapy for tuberculosis. Patients start to recover immune function with the start of treatment for tuberculosis and initiation of new antiretroviral medications, that is immune reconstitution inflammatory syndrome. The IDSA guidelines help outline what to do in this situation. 3. Drug discontinuation usually resolves fever in 2 to 3 days. Reintroduce drugs as for rash. Optic neuritis is usually associated with ethambutol, which should be discontinued. Least necessary drug in the acute care therapy plan. We will now look at hepatotoxicity from antimycobacterial drugs. A. 20% of patients will see an elevation in ALT during treatment. This may or may not prompt discontinuation. B. Baseline LFTs are performed and may be repeated if the patient is symptomatic or at risk for hepatitis or is taking concomitant hepatotoxins. C. Suspect drug-induced hepatitis if patient is symptomatic and ALT is greater than 3 times the upper limit of normal, abbreviated as ULN, or asymptomatic and greater than 5 times the upper limit of normal, ULN, if our patient was asymptomatic, but greater than 6 times the upper limit of normal, ULN. Then do the following. 1. Rule out other drug or viral-induced hepatitis. 2. Discontinue all antimycobacterial therapy. 3. Reintroduce meds at 1-week intervals when ALT declines to less than 2 times the upper limit of normal, ULN. Re-challenge rifampin first, followed by INH, then PZA. D. All of drugs can cause hepatotoxicity, with pyrazinamide as the most common. Isoniazid and rifampin are less common but still of concern. We will now look at handling interruptions in therapy. A. During intensive phase. 1. If interruption is less than 14 days, continue treatment to complete total planned doses, as long as phase is completed in 3 months, instead of 2 months it was supposed to take. 2. If interruption is equal to or more than 14 days, restart therapy from the beginning. B. During continuation phase. 1. If equal to or more than 80% of doses were given A, and sputum was originally smear negative, we may be able to stop treatment. B, and sputum was originally smear positive, complete course. 2. If less than 80% of doses were given A, and all missed doses are less than 3 months total but not greater than 2 consecutive months, complete therapy. B. And all missed doses are greater than 3 months total or greater than 2 consecutive months. Restart entire regimen from beginning, including the intensive phase. For how long should therapy be continued? A. The intensive phase should be continued for 8 weeks, that is 2 months. B. If sputum culture has not converted to negative by 16 weeks, that is 4 months, susceptibility tests should be repeated and therapy modified as necessary, i.e., if resistance is detected or reported. C. The continuation phase is determined by various factors. Pause the video and scrutinize the table. Let's now discuss failure of initial antitubercular therapy. It is generally defined as continued positive cultures after 4 months of therapy, 2 months intensive, 2 months continuation. Causes. They include 1. Resistance, 2. Noncompliance, and 3. Malabsorption. Actions. We should do the following: 1. Send isolate for new susceptibility testing. 2. In the interim, A. If the patient does not appear clinically ill and smear negative, can wait for susceptibility results. B. If the patient appears clinically ill and/or has a positive sputum smear, add 2 to 3 additional drugs to the regimen. Never add a single drug in this circumstance. Let's now discuss treatment of other types of M. tuberculosis disease. A. Latent tuberculosis, which is both TST and IgRA positive, with no evidence of disease, decision to treat or empirical treatment already started. The options include 1. INH and RIF for 2 months, 2. INH for 9 months. This is the most common option. 3. RIF for 4 months, 4. INH plus rifapentine for 3 months. B. Culture-negative tuberculosis, which is TST and IgRA positive, clinical or radiographic evidence of disease, negative cultures. The intensive phase therapy should last 8 weeks, followed by INH and RIF for 8 weeks. Let's now discuss treatment of extrapulmonary tuberculosis. A. It involves 8-week intensive phase therapy for all types. B. Lymph node TB, requires a 4-month continuation phase. C. Skeletal tuberculosis, requires a 7 to 10-month continuation phase. D. Pericardial tuberculosis, requires a 4-month continuation phase. E. Pleural tuberculosis, requires a 4-month continuation phase. F. Tuberculosis meningitis, requires a 7 to 10-month continuation phase. G. Disseminated tuberculosis, requires a 4-month continuation phase. H. Genitourinary tuberculosis, requires a 4-month continuation phase. I. Abdominal tuberculosis, requires a 4-month continuation phase. J. Skeletal and CSF tuberculosis need a longer continuation phase versus other types. Let's now discuss the treatment of drug-resistant tuberculosis. Definitions. 1. Rifampin-resistant RRTB is the most ominous. 2. Multidrug-resistant MDR-TB is TB that is RIF and INH resistant. 3. Extensively drug-resistant XDR-TB is TB that is resistant to RIF, INH, and other first-line drugs. Implications of resistance. It leads to 1. Longer duration of therapy, 2. Use of second-line or third-line agents, and 3. Surgical intervention may be considered. A. Partial lung resection, lobectomy or wedge resection, recommended over total lung resection. B. For patients where bacteriological and radiographic evidence in conjunction with clinical judgment suggests a strong risk of relapse or failure of treatment with medications alone. C. Treatment options by group according to the World Health Organization. Group A includes levofloxacin or moxifloxacin, bedaquiline, and linezolid. Group B includes clofazimine, cycloserine, or taururzidone. Group C includes ethambutol, delamanid, pyrazinamide, imipenem cilastatine or meropenem, amikacin or streptomycin, ethionamide or prothionamide, para-amino-salicylic acid. Let's now discuss the treatment options by steps according to the ATS, CDC, ERS, and IDSA. Step 1 Moxifloxacin, levofloxacin. Step 2 Bedaquiline, linezolid. Step 3 cycloserine, clofazimine. Step 4 amikacin, streptomycin. Step 5 pyrazinamide, ethambutol, delamanid. Step 6 ethionamide or prothionamide, high-dose isoniazid, p-aminosalicylic acid, imipenem cilastatine clavulanate or meropenem clavulanate. 7. The following are no longer recommended: A. Capreomycin and kanamycin. B. Amoxicillin, clavulanate when used without a carbapenem. C. Azithromycin and clarithromycin. Let's now discuss the treatment of drug-resistant tuberculosis, standardized, short-course regimen. For RRTB and MDR-TB, a short-course regimen may be used, according to the World Health Organization. 1. Intensive phase lasting 4 to 6 months to include A. PZA, B. 1 drug from Group A, fluoroquinolone. C. 1 drug from Group B, aminoglycoside, usually kanamycin. D. 2 drugs from Group C, usually ethionamide and clofazimine. E. High-dose INH and/or EMB, the continuation phase lasting 5 months to include A. fluoroquinolone, B. clofazimine, C. PZA, and D. ethambutol. B. The official guidelines of the ATS, CDC, ERS, and IDSA for MDR-TB cannot make a recommendation either for or against the standardized short-course regimen. Let's now discuss special considerations for drugs used to treat MDR-TB. Adverse effects. 1. Aminoglycosides cause nephrotoxicity and ototoxicity. 2. Bedaquiline causes QTc interval prolongation. 3. Clofazimine causes skin discoloration. 4. Cycloserine causes CNS effects when serum concentrations are greater than 35 mcg per milliliter. 5. Moxifloxacin causes QTc interval prolongation, tendinitis, and CNS stimulation. 6. Linezolid causes cytopenias, and peripheral neuropathy. Drug-drug interactions. 1. Bedaquiline is a CYP3A4 substrate. 2. Oral fluoroquinolones are chelated by oral polyvalent cations. 3. Linezolid interacts with selective serotonin reuptake inhibitors. Let's now discuss overview of nontuberculous mycobacteria, NTM taxonomy. 1. Well over 100 different species have been identified. 2. It is ubiquitous, and occurs in soil, water, including treated water. 3. There is very little evidence to support human-to-human transmission. 4. There are nearly 20 species documented to cause disease in humans. Rapid and slow-growing strains. Most infections are asymptomatic and/or self-limited in nature. Risks for infection: A. Via direct inoculation or inhalation. B. Due to compromised immune status. In the case of 1. Lymphopenia, i.e., HIV, and 2. Genetic or iatrogenic suppression of interferon gamma, tumor necrosis factor alpha, and/or interleukin-12 synthesis and response pathways. Let's now discuss rapid growers versus slow growers. Rapid growers. 1. They form mature colonies on solid media within 7 days. 2. They are more often associated with skin, soft tissue infection, but can cause pneumonia. Examples: they include A. M. abscessus, B. M. chelonae, and C. M. fortuatum. Slow growers are more like tuberculosis. A. They form mature colonies on solid media after 7 days. B. Some cause skin, soft tissue infection, but they more often cause pulmonary or disseminated infection. Examples: they include 1. M. avium, 2. M. kansasi, and 3. M. bovis. Let's now discuss the spectrum of disease due to non-tuberculous mycobacteria (NTM). Pulmonary disease, various. 1. They are variable and nonspecific. 2. Their symptoms include cough, with or without sputum production, fatigue, weight loss, malaise, dyspnea, fever, hemoptysis, and chest pain. 3. On physical exam, rhonchi, crackles, wheezes are heard. Chest radiograph. 1. Fibrocavitary, similar to Mycobacterium tuberculosis. 2. Nodular infiltrates or bronchiectasis. Disseminated disease, M. avium. 1. Because primarily in HIV-infected, CD4 plus T-cell counts less than 50 per microliter. 2. Its symptoms include fever, night sweats, weight loss, abdominal pain. On physical exam, abdominal tenderness, hepatosplenomegaly, often present before bacteremia are observed. Lab tests. 1. Anemia. 2. Elevated alkaline phosphatase, lactate dehydrogenase. 3. Bacteremia. Let's now discuss diagnostic workup for NTM pulmonary disease. PD3 sputum samples for AFB smear and culture are needed. High-resolution CT scan. To confirm NTM-PD if 2 to 3 sputum samples are NTM positive. And to guide bronchoscopy, lavage, biopsy, if 0 to 1 sputum samples are NTM positive. NTM rapid identification by NAAT initial susceptibility testing should be done. 1. M. avium treated using clarithromycin, amikacin. 2. M. candidacy treated with rifampin. 3. M. abscesses treated with clarithromycin, cefoxitin, amikacin, tigecycline, moxifloxacin, imipenem, minocycline, linezolid, cotrimoxazole, clofazimine. Let's now discuss oral treatment of infection due to Mycobacterium avium. Primary prophylaxis against disseminated MAC disease is not recommended for adults and adolescents with HIV who immediately initiate ART. Pulmonary infection, treat until culture negative for 12 months. Thrice weekly regimen is okay if smear negative and no cavitation. 1. Clarithromycin S, clarithromycin or azithromycin plus ethambutol 15 to 25 mg per kilogram plus rifampin 600 mg, all thrice weekly. 2. Clarithromycin R, rifampin plus ethambutol plus isoniazid or moxifloxacin plus aminoglycoside IV. Disseminated infection in HIV infected, treat for minimum of 12 months and CD4 plus greater than 100 cells per millimeter cubed for 6 months. 1. Clarithromycin S, clarithromycin or azithromycin plus ethambutol A. Add rifabutin if HIV infected and CD4 plus less than 50 cells per millimeter cubed, high-grade bacteremia greater than 100 CFU per milliliter, or absence of antiretroviral therapy. 2. Clarithromycin R, rifabutin plus ethambutol plus moxifloxacin plus aminoglycoside. Let's now discuss Mycobacterium candidaceae. A. It is the second most common cause of NTM disease in US. B. It colonizes tap water. C. Its clinical presentation of pulmonary disease is very similar to pulmonary tuberculosis. D. Treatment of pulmonary disease, treat until culture negative for 12 months. 1. Rifampin S, daily rifampin plus ethambutol 15 mg per kilogram plus isoniazid or azithromycin or clarithromycin, twice daily. 2. Rifampin R, treat with a 3-drug regimen based on susceptibility testing. E. Disseminated disease, same regimen as for pulmonary disease. Let's now discuss Mycobacterium abscessus. A. It is geographically seen most often in southeastern United States. B. It is a rapid-growing organism. C. Diseases. 1. It causes skin, soft tissue, skeletal infection following direct inoculation, during trauma, or surgery. 2. Respiratory infection is less common, but most common rapid grower to cause respiratory disease. in patients with chronic lung disease. D. Clinical presentation. 1. Skin, soft tissue, skeletal presence as abscesses and regional lymphadenopathy. 2. Respiratory presents as reticulonodular abscesses. Let's now discuss adult treatment of infection due to Mycobacterium abscessus. A. Skin, soft tissue, skeletal infection. It is treated using the following. 1. Oral macrolide, azithromycin or clarithromycin plus 2. IV amikacin 10 to 15 mg per kilogram daily. 3. IV imipenem 500 mg 4 times a day. B. Duration of therapy. 1. Skin, soft tissue, for 4 months. 2. Skeletal, for 6 months. Pulmonary infection. 1. Typically more difficult to treat, eradicate, surgical resection may be indicated, treat until culture negative for 12 months. 2. Clarithromycin S.A. IV amikacin daily to thrice a week, plus twice daily. Tigecycline, imipenem, clarithromycin for 1 to 6 months, then nebulized amikacin plus 3 oral drugs found to be active. 3. Clarithromycin R.A. IV amikacin daily to thrice a week plus twice daily. Tigecycline, imipenem for 3 to 6 months *, then nebulized amikacin plus 3 oral drugs found to be active. D** duration of IV therapy will depend on whether clarithromycin S strain shows inducible resistance and clinical response after 3 months. Let's now discuss special considerations for drugs used to treat NTM. Adverse effects. 1. Macrolides may cause hearing loss, QTC prolongation, hepatitis, and GI upset. 2. Aminoglycosides may cause nephrotoxicity and ototoxicity. 3. Moxifloxacin may cause QTC prolongation, tendinitis, and CNS stimulation. 4. Rifabutin may cause polymyalgia, polyarthralgia, and leukopenia. 5. Linezolid may cause cytopenias and peripheral neuropathy. 6. Beta-lactams may cause C. difficile infection or diarrhea. Drug-drug interactions. 1. Macrolides with other drugs metabolized by CYP3A, note rifabutin, tacrolimus. 2. Oral moxifloxacin is chelated by oral polyvalent cations. 3. Linezolid interacts with selective serotonin reuptake inhibitors. And now, in conclusion. A. Screening for and diagnosing tuberculosis and other mycobacterial infections requires assessment of risk factors, symptoms, and various diagnostic test results. B. Multiple drug therapy is used on a long-term basis, and the medications can interact with other drugs and cause adverse effects that interfere with adherence. And C. Infectious disease pharmacists can play an important role in recommending drug therapy and educating patients about the importance of adherence. Thank you.